Welcome to the Remdesivir Files, a COVID-19 Chronicle. In today's episode, we'll explore a crucial aspect of the Remdesivir story, the scarcity crisis that arose during the peak of the pandemic. As the demand for Remdesivir surged, hospitals and healthcare systems faced a daunting challenge: how to ration a life-saving drug in short supply. We'll be diving into the pharmacoeconomics of rationing, examining the delicate balance between supply and demand, and how hospitals navigated the complex task of triaging remdesivir use. Joining me today is Saakshi Sharma. Welcome to the show.
Thank you so much for having me. It's a pleasure to be here and discuss such an important and complex issue.
Let's start with the demand supply mismatch that led to this crisis. During the height of the COVID-19 pandemic, remdesivir was one of the few antiviral treatments available. Could you walk us through the dynamics that led to this scarcity? Specifically, how did the rapid escalation in demand compare to the drug's manufacturing and distribution capacity?
The demand-supply mismatch during the pandemic was a critical issue for remdesivir, and it stemmed from several factors. Initially, remdesivir was one of the first drugs to be recognized for its potential in treating COVID-19, which quickly led to widespread global demand. However, this was happening while the pharmaceutical manufacturing processes were still being scaled up to meet that particular demand. The production of remdesivir, as with many complex drugs, is not instantaneous. The drug requires specific chemical synthesis and formulation processes, which are time consuming, and also require significant raw materials and laboratory facilities. The formulation for intravenous use also added complexity, as we discussed in the earlier episodes, with challenges related to stability, solubility, and infusion compatibility. As the pandemic progressed, the urgency to supply remdesivir clashed with the realities of manufacturing at scale. Gilead Sciences, the maker of remdesivir, initially could not meet the global demand, leading to supply shortages. Logistics became another issue. Coordinating distribution across countries with different healthcare infrastructures added an additional layer of complexity. In many cases, hospitals were forced to prioritize who would receive the drug, based not on just a clinical need, but also on availability. The manufacturing capacity was eventually ramped up, but even at full production, the sheer volume of patients requiring treatment far outpaced the available supply. This is where pharmacoeconomics and analysis of costs relative to the outcomes became crucial.
You have touched on the manufacturing capacity, and as we know, producing drugs at scale isn't as simple as just increasing production. There's also the economic aspect. Let's talk about the pharmacoeconomics of rationing. How did hospitals approach the decision-making process when they had to allocate limited doses of remdesivir? What factors did they consider?
The pharmacoeconomics of rationing remdesivir in the face of scarcity is complex. Hospitals had to consider several factors when determining who would receive the drug, and these decisions were not only based on clinical effectiveness, but also on economic principles of resource allocation. One key aspect was clinical outcomes. Hospitals needed to consider which patients would benefit most from remdesivir based on several factors like severity of the disease, age, comorbidities, and other treatment options. For example, early stage patients with mild to moderate symptoms might not benefit as much from remdesivir as patients with severe cases requiring hospitalization. In some hospitals, guidelines were established that prioritize those with the highest likelihood of benefit, such as patients requiring oxygen therapy or those on ventilators. But economics came into play as well. Given the high cost of remdesivir, especially when the supply was limited, hospitals had to weigh the cost effectiveness of using the drug in most resource intensive cases. In some settings, a triaged system was employed where the most critical patients were prioritized. This was a difficult decision because each hospital had to balance clinical judgment with the broader goal of maximizing the overall health benefit of available resources. Additionally, hospitals had to consider other aspects such as the availability of alternate treatments. For instance, steroids like dexamethasone were more widely available and had shown effectiveness in treating COVID-19. So some hospitals chose to reserve remdesivir for cases whereas the other treatment were not sufficient at that time. This led to complex decision-making frameworks. For example, triage committees and ethics boards within hospitals often had to get involved in these decisions, especially when the allocation was being done on a larger scale with limited doses available. The hospitals also considered their existing stock of remdesivir and how to ensure equitable distribution across various patient groups, which was especially tricky in areas with high infection rates.
That brings us to the issue of clinical triage and how it was handled in real world hospital settings. Hospitals don't just have a handful of patients, they often have dozens, if not hundreds, of COVID-19 patients who could benefit from remdesivir. How did they organize this triage? Was it based purely on clinical severity or were there any other considerations?
Hospitals used various strategies to organize triage for remdesivir, and these systems were designed to ensure that the drug was used effectively and fairly. There were multiple clinical factors involved in triaging patients, and each hospital had to adapt based on the patient population they were treating, the available data on remdesivir's efficacy, and the capacity of their healthcare system as well. One of the first steps in triage was evaluating clinical severity. Patients with severe disease, for example, those who were on mechanical ventilation or high flow oxygen, were prioritized because remdesivir had shown the most promise in improving outcomes for critically ill patients. This priority system, however, was not always clear-cut. Some hospitals considered factors such as the duration of symptoms, viral load, and the timing of drug administration, all of which could affect how well a patient would respond to the drug. In some settings, hospitals also factored in the availability of alternative treatments such as dexamethasone, which had become a mainstay in managing COVID-19, particularly for patients with more severe disease. If a patient was already receiving steroids and was not on the verge of critical illness, remdesivir might not be administered, especially if the hospital had to prioritize those with more immediate and severe needs. There was also consideration of age and comorbid conditions. Older patients or those with underlying conditions such as diabetes, hypertension, or heart disease were more likely to experience severe disease and complications. As a result, some hospitals focused on ensuring these patients had access to remdesivir given their high risk of poor outcomes. Finally, hospitals also had to consider logistical and operational factors. For example, how many patients could be treated with the available supply of remdesivir? Could some patients be treated with alternative drugs that were more readily available? These considerations often determined whether remdesivir would be part of patients' treatment plan, and the availability of other therapeutic resources often influence these triage decisions.
It's fascinating how many layers they add to the decision making process when allocating a scarce resource like remdesivir. Let's talk briefly about ethical considerations in this context. Hospitals had to make difficult choices, often with limited guidance. How did healthcare professionals navigate these ethical dilemmas, particularly when it came to determining who should receive the drug?
Ethical considerations were a significant part of the triage process in situations where resources are limited, such as during a pandemic. Hospitals often find themselves in a position where they must make decisions that impact patient outcomes in ways that go beyond medical need alone. A key ethical principle that hospitals focused was fairness. Triage decision had to be transparent and based on clinical criteria, avoiding bias based on factors such as race, gender, or socio-economic status. Many hospitals implemented ethical guidelines to help ensure that decisions about who would receive remdesivir were based purely on medical need and probability of benefit rather than extraneous factors. Another principle at play was maximizing overall benefit, or what is often referred to as the utilitarian principle. This principle suggests that in cases of scarcity, resources should be allocated to those who are most likely to benefit from them, thereby maximizing the overall health outcomes across the population. At the same time, individual patient autonomy had to be respected, meaning that patients had the right to be informed about their treatment options, including the potential risks and benefits of receiving remdesivir. Hospitals had to balance these ethical principles with the practical realities of a healthcare system under immense strain, which meant difficult decisions were made on a case by case basis.
Thank you, Sakshi, for sharing your expertise on this incredibly complex aspect of remdesivir's use during this pandemic. Stay tuned. See you in the next episode.